So just to let you know, I'm the Professor of Neurology at Barts in London, down the road. And I've been working in multiple sclerosis now since 1993, when I came to London to do my PhD. And we had a meeting at the MS Society this morning to discuss quite an innovative clinical trial. And the clinicians amongst the group were just reminiscing about how different things were in 1993 to 2014. So we didn't have any disease-modifying therapies in 1993. And when I used to do a ward round with Professor Ian MacDonald, there was always 2, 3, maybe 4 patients on the ward with major relapses. And we don't see that anymore. The only time we see anybody come into hospital with a relapse is somebody who presents with their first clinical event and usually gets admitted by a casualty and they haven't got a diagnosis yet. So we're not seeing big relapses. And we also used to see people with complex problems, pressure sores and a whole lot of other things, and we don't see that anymore. And the reason is that almost certainly disease-modifying therapies are having a major impact on what's happening to this disease, and we need to get that message across that we are changing the prognosis and the natural history of this disease by our treatment. So if you go to our blog, you'll see this particular picture. So this is kind of like I like to think of MS. It's called the Allistic Approach to Multiple Sclerosis. And it starts off it's an analogy of the London Underground tube map, if you recognize it. And it starts off really over there at somebody who's at risk of the disease, and you move across to a person who's got asymptomatic disease. Then the first clinical event, CIS. Then we've got minimal, moderate, severe impairment, and we go into what we call the terminal phase, where people have got lots and lots of problems. And each of these lines represents a different need. So if we have to manage MS, we have to manage it across the whole course of this disease. All right? But today I'm going to focus, because of the limitations in time, really on disease-modifying therapy. So therapies that hopefully will, when given early, stop you moving across this and stop all the stuff, all the needs at the end of this disease. So that's the whole aim of our treatments, is to try and prevent people from moving along this journey and keeping them well and healthy. So to empower yourselves, these are the questions we're going to go through. You need to ask these questions of your neurologist or your MS nurse or the team looking after you. And I'll try and go through all of these as much as today. If we can't, we'll probably stop down around about point 7. So are you sure you have MS? And this is a very important question, because about 1 in 20 people diagnosed with MS don't have the disease. And we know that because when people who've been diagnosed with multiple sclerosis die and come to post-mortem, in other words, the pathologist looks at them, there's a misdiagnosis rate of about 1 in 20. And we think that's probably not far off still today. And the reason why it's very, very important to have the correct diagnosis is that the treatments and the response to treatments vary. So who knows about the drug Tysabri, natalizumab? Most people don't know about it. So when they did the very, very first trials, and one of the patients got that very, very severe complication, PML, from that and died, when that patient's brain came to post-mortem, she did not have multiple sclerosis. So she'd been on this treatment, and probably she had migraine. And she was misdiagnosed as having MS, and she was put on this treatment and developed a complication of this treatment and died. So the consequences of misdiagnosis are not insignificant. Okay? And there are some conditions that mimic MS, and the most important one is this condition called neuromyelitis optica. We now kind of think we know how to diagnose this and separate out from MS, but when you do get diagnosed with this and get put onto, for example, interferon beta, it can make that condition a lot worse. Okay? And I put up here migraine as an example. But there are lots of other conditions that can mimic MS that need other treatments. So we as neurologists spend a long time making sure we get the diagnosis right so we can give you the right treatment. The next question is what type of MS you have. And you all know at the moment we only have therapies that are licensed for people with relapsing MS, people who are having clear attacks. We do not have therapy at the moment for people with progressive disease. These are people getting worse slowly. That doesn't mean to say we're not going to have therapies for those people, because there's currently a whole handful, or even more than a handful, of clinical trials trying to develop drugs for people with progressive MS. Then a very important question now, particularly now we've got large numbers of therapies, is what prognostic group do you fall into? And the reason for this is that if you've got a very poor prognostic profile, in other words, you're going to do badly, you're much more likely to take on more risky therapies than if you have a good prognostic profile. Okay, so these are some of the factors that we take into account. Somebody who's older, believe it or not, when presenting. Males do worse. People who have multiple lesions when they're multiple sites. People who present with motor, walking problems, and coordination problems and bladder problems. In comparison, people who present with purely sensory attacks or just visual attacks have a better prognosis. Full recovery from attack is a good prognostic sign. If you have an incomplete recovery, it's a poor prognostic sign. If you've already got some disability, if your scan has got a large number of lesions, for example, and there's some other factors like the CSF analysis, but we as clinicians pigeonhole you into little categories because our kind of therapies we offer in different brackets vary. So the idea then would be to say, and I'll just call it 3 categories. You've got a very favorable prognostic profile, so you're much more likely to end up in the future having benign MS. Or you've got a very poor prognostic profile. If we didn't treat you, you're going to really do badly. And then there's the majority of people actually fall in the middle. We're not sure what's going to happen. And our aim really is, obviously, to try and get people into this favorable bracket as possible. And the reason, if we're indeterminate, we will monitor you. I would not monitor somebody with MS in case if their disease becomes more active, we can shift them to more effective therapies. Okay? But we also got to remember that even if you've got a favorable profile, sometimes the disease can flare up again and you can do badly. So the bottom line is if you've got multiple sclerosis, you should always be monitored. You should not be monitored. And this is the therapeutic aim, is to make everybody move up into the top profile. Okay? So can we convert everybody to have benign MS? So this is kind of how we have it in the UK. If this big bubble here is relapsing multiple sclerosis, there are some people who have inactive disease. Their disease is in long-term remission, and they haven't had any clinical attacks, and their MRI scans are quiet, and they may remain inactive for 5, 10, 15, 20 years. We have no idea. We're not allowed to use disease-modifying therapy in people who don't have any evidence of activity. And we define activity essentially as having the criteria now changed. If you just had an attack in the last 2 years, or your MRI scan shows new lesions coming in the last year, or an active lesion, when you get given that contrast agent, gadolinium, it lights up, that means there's ongoing inflammation and you reconsider to have active disease. Then NICE, the organization allows us to prescribe these drugs, and NHS England recognize another 2 categories. So this is somebody who's got highly active disease. So this is somebody who's had 1 clinical attack that's disabling in the last year with an active scan. And then there's other smaller group called rapidly evolving severe. And this is having 2 clinical attacks that are disabling in the last 12 months with an active scan. And the reason why these are important is for therapies. So for example, we can only really give you fingolimod, the tablet, if you failed interferon therapy and you fit into the highly active box. And we can only give you Tysabri, natalizumab, if you fall into the rapidly evolved severe group. So these categories have prescribing implications. And what we want to do with our therapy is really shift everybody from these groups into this group here, to the inactive group. And by switching off all the inflammation and getting rid of all those relapses and all those new lesions, we'll hopefully make people stay stable for years and years and years and decades. That's the aim. Any questions on this? You understand now what we're trying to do? Okay, I'll take you through this a little bit more. So now let's take you back to the early therapy strategy. Let's say this is a population of newly diagnosed people with clinically isolated first attack or MS. And most people are fully active, really, when they have their first attack and recover from it. And if we let the disease run its natural course, you'll find that very few people are left without any problems over time. Most people end up with walking problems, wheelchair, and some people will end up dying early from their disease. Okay, and it's something that people don't like to hear, but on average, people with multiple sclerosis live about 10 years less than the average population before they had treatments. So this is before treatments. And what we'd like to do is we'd like to do this. We'd like to actually shift everybody into that group and try and limit the number of people becoming disabled from this disease. So this is kind of what our therapeutic strategy is when we treat groups of people. Okay? Make sense? The same thing happens in cancer therapies, for example. You know, in the past, this could have been, say, lung cancer. Oh, lung cancer, we haven't got it very effective. This could be breast cancer. And what breast cancer therapies have done now is that they've really made an enormous difference to the cure rates and survival rates of women. Okay? So a woman now presenting with breast cancer has got about a 70% chance of being cured of their disease because of new treatments. And we're trying to do the same with MS. We're trying to prevent people from becoming disabled. Now, that's the aim. And when you're making a decision about treatments, you always got to balance it against the risks of the drug. But you've also got to balance it against the risks of the disease. And this is where people with MS get upset with me for telling you and reminding you about how bad MS is. But you have to appreciate how bad MS is to make a decision about some of the new treatments, because some of the new treatments have significant side effects and risks attached to them, and you need to work out the risks and balances of these two things. And utility, and I always put this up to tell people how the population rates MS. Utility is a quality of life measure. So when you're born with a perfect quality of life on the first day, and then it drops off over time, and then when you die, you've got a quality of life of 0. Okay? And this over here is the disability score, the EDSS score. Well, just to orientate you, when you get to EDSS of 6, you need a walking stick, 6.5, 2 walking sticks, 7, you need a wheelchair, and when you get to 9, EDS 8 and 9, you basically need help with your upper limb function. 8 will be in a wheelchair all day, 9 probably in bed most of the day. So this is the disability scale. And what's incredible, when the study was done in the UK, society, this is the general population, rated people with a disability score of 8 and 9 as having a quality of life worse than death. Okay, and you can see the quality of life dropping off as people become more disabled. So the message here is, if we want to make a big difference to the quality of life of people with a disease, we need to stop them becoming disabled, and we need to make sure that they have very little disability. So that's the whole strategy that's been adopted of us making the diagnosis as quickly as possible and starting treatment as quickly as possible, where you have the most to gain from the therapies. There's no point in waiting until you become more disabled, because you've missed the boat, and we can't go back in time. And this is I'm not sure if when Diane Playford put this slide up, but she probably spoke about this. Being employed is a badge of health, essentially, and this is the impact that MS has on work status in the EU. 50% of people are unemployed with an EDSS of 3. So if you saw somebody with MS walking in here with an EDSS of 3, they would look normal to you. We'd have to examine them to be able to give them a score of 3. So that on outer appearances, they'd look normal. Which means that something's driving this early unemployment rate that's not picked up by physical disability. And that's almost certainly related to cognitive problems, depression, anxiety, and fatigue. So the message here is that MS is very disabling, even when you're not that disabled on the disability score, which is another reason why we need to treat as much as possible. And this, by the way, is about 10 years into the disease on average. And the average age of onset of MS is 30. So this is happening at about the age of 40, when you're in the prime of your life. Now, the news here is that this study, although it was published in 2006, was done in 2004, in a period of time where we had not very effective therapies, and quite a few people weren't on treatments. So I think this is historical, and it's going to be a lot better if we have to repeat it now with our new treatments. So don't get too depressed over this figure. I'm almost certain it's going to improve you know, if we had to repeat this study now with more effective therapies. So one of the things I've developed is a infographic, which is the buzz term for these, and you can get it on our blog. It basically goes through, in very simple terms, all the negatives, the risks associated with not treating MS. Okay? I'm not going to go through them all, but it goes through all the negative impacts. And when you read it, people with MS get a shock because they went, a large proportion of people with the disease are not ever given this information early on in the course of their disease. And I don't make apologies for it because I think if you've got the disease, you need to know this because this is what we're trying to prevent. And if you don't know this, how the hell are you going to make a decision about a treatment that may cause a big problem in your life as a consequence of the treatment? So you need to know this to balance up the risks and benefits of the therapies. So you also need to ask your neurologist, do you have active MS? So if you're worried about not being on a treatment and you want to be on a treatment, you really need to ask the question, is your disease active? And we tend to monitor the disease clinically in most parts of the country. But it's quite clear that this is not good enough, and you really, to be on top of this disease, you have to have regular MRI scans because it's now quite clear that the inflammatory activity, the lesions that come and go, also cause damage, and those in themselves are a marker of active disease. And even NICE and NHS England have recognized this now because with the new drug alemtuzumab, okay, it's licensed for people, adult people with relapsing disease, with active MS defined clinically on relapses, or on MRI. So they've got an or there. So for the first time, our NHS England is allowing us clinicians to make decisions based on MRI monitoring. Unfortunately, not all MS centers in the country monitor on MRI, but I think over the next 5 to 10 years, we're going to start seeing clinicians doing much more frequent MRI scans to monitor this disease. Okay? And I'm not going to make an excuse for it. If you're not getting monitored with MRI scans, you need to ask why you're not getting monitored with MRI scans. Okay? And I put biomarkers here. This is not so much in people starting treatment, but some people who are on, example, interferon beta, their own immune systems make antibodies to the drug and stop the drug working. So part of our monitoring is to make sure that those people don't stay on the drug. So we do regular tests for these neutralizing antibodies. Next question you've got to ask, am I eligible for a treatment? Okay? You'll be surprised that this varies depending where you go. All right? And it also depends on your worldview. So somebody with multiple sclerosis would like to say, I'm eligible. Neurologists may say, you're eligible. But at the end of the day, in the United Kingdom, the payers, the NHS, and the regulators, the European Medicine Agency, decide really about the eligibility criteria. And we can't really prescribe outside those eligibility criteria. Okay? If they came and audited our books and they found we're prescribing off-label, okay, then they will make the hospital pay rather than NHS England pay. And our hospitals are all essentially bankrupt or very tight on money. And I'd get into a lot of trouble from my managers if I was prescribing drugs. So we have a system in our hospital to check, to make sure that everybody who gets put on a therapy who need therapies, they're eligible for that treatment. And it's quite upsetting for people with the disease when we say, unfortunately, you're not eligible for natalizumab because you haven't had 2 disabling attacks in the last 12 months. They get quite upset with you, but that's unfortunately the criteria. And our hands are really tied. We can't change that. We can't change that. And this is just giving you an example of NICE who make these decisions, and they will have a guidance, and this refers to Tysabri. And you'll see it's licensed for people with highly active, rapidly evolving severe MS. Now, the other thing you need to ask the question now for the first time we have this opportunity is, do you understand the difference between treatment strategies of maintenance and escalation and induction therapy? Do you understand those differences? Some people are shaking their heads. Okay? And this has got to do with the treatment philosophy normally of the neurologist, because they differ, but sometimes people with the disease also differ, and they find the neurologists who match up to their own expectations to get treated, and this happens all the time. So I get a lot of people coming to my clinic wanting a specific treatment because they understand that I'm prepared to go for the induction therapies if their patients want them. And the difference is that, maybe this next slide is better, but the difference is the so-called maintenance escalation is you start somebody off on a first-line treatment, a less effective therapy, and you see how well they do. And if they're not doing very well, you put them onto more effective therapies and you go up a ladder. The induction therapy is you start people on the big gun straight away and try and give them the biggest treatment to the first line. Okay? Induction therapy is also, by definition, a course of therapy and then nothing, because that treatment is trying to get rid of the autoimmune disease. Whereas a maintenance treatment, you've got to continuously take the drug. Okay, and if you stop the drug, the MS will come back. So there's differences between the two. Okay. Now the only induction therapy, we've got licensed in the UK, and it's just come along as Lemtrada, alemtuzumab. So this is a therapy that's given by intravenous infusion. In the first year, you get 5 courses, 5 days of therapy, and it basically depletes your immune system and allows it to come back. And in year 2, you get 3 courses, 3 days of it, and allows your immune system to deplete it and come back. And hopefully when the immune system comes back, that autoimmunity is disappeared. And we're now beginning to see by following these patients up that about 50% of people treated with alemtuzumab only need those 2 treatments. So they go on for 5 to 7 years, and the disease is in long-term remission. Long-term remission. About 30% will need 3 courses to go into long-term remission. About 15% need 4 courses, and very few people have needed 5 courses of that therapy. Okay? Whereas the other strategy, you need to take the drugs all the time. So this is how we actually manage it. You get somebody with multiple sclerosis. We kind of profile them in terms of prognosis. Okay, lifestyle and goals. Now, what's a very important question here is if you're a young lady, because MS is a disease, it's a pink ribbon disease essentially. The male to female ratio is 1 to 3. So a large number of women want to have families. So a big decision making here is what therapies they would want has got to do with pregnancy and having families. So it's not always about effectiveness. But you then choose a therapy, and we like to involve patients as much as possible. We then treat you with one of these therapies. Okay? We have this thing called rebaseline when we, at our institution, it varies depending on which drug we're on. We do another brain MRI scan after the drug is working. And then we monitor you every single year. We monitor you clinically, and we do an annual MRI scan. And obviously, if the disease isn't under control and you get breakthrough activity, we go back and we switch therapies, okay? So it's this endless loop. And the aim really is to treat, to target, and get rid of all the inflammatory activity, because we know from the trials that people who've got no relapses, no MRI activity, in other words, rendered activity-free, do much better than people who are left with some disease activity. That make sense? This is how the rheumatologists treat rheumatoid arthritis. They also treat the target to try and suppress all inflammation in the joints as well. And the aim is to protect the joints. So we have a treatment ladder. Very soon we're going to have 5 first-line therapies. Interferon beta, glatiramer acetate or Copaxone, teriflunomide, DMF, Tecfidera. What's the other one? Well, it depends where you are in the world. Fingolimid's another one, depending on where you are in the world. It's an oral tablet. In the UK, it's a second-line therapy. Okay, so you can go into a first-line therapy. We monitor you. If you fail, we put you onto the next tier, which is more effective. If you fail that, we're onto the next effective. Okay. The problem with this is that waiting for you to see if you respond or not, and you have attacks, you may acquire damage during that period of time. You may acquire damage. And unfortunately, if you do acquire damage, we can't go back and change our minds. So this can be quite risky. And there's now data that's come out of a big international registry saying that people who stay on this particular red rung twice, if they go so from interferon beta to glutaric acetate before moving up, do worse than people who move up after one shot. So in large parts of the world now, most of us are saying, if you are going to go this strategy, for whatever reason, we only give you one option down below, and if you fail on the first tier, we move you up to the more effective straight away. We don't switch you between the first-line therapies. It's a game of numbers. It's a statistical game. You're much more likely to do poorly if you have to cycle through less effective therapy. So we try and move you up as quickly as possible. And then there is an option of going to this straight away. I don't know if you're aware that alemtuzumab has been given a first-line license as well. It's one of the most effective therapies we've got. And there are some people who can have it first line. So we can avoid going through these two fears straight to this. What you've got to realize is these therapies that are the most effective also are the ones that come with the most risks. And that's the balancing act. And there is no rule that applies to everybody, because everybody's risk threshold differs. So this is why we talk about individualized treatment decisions. So somebody will be completely scared of this tier and would almost certainly want to go this route. Somebody may not be scared of this and want to go there straight away. Somebody may be scared of this, okay, and start here, but when they have a big attack and realize that this disease could disable them, will want to go there without going through that. So there's a whole lot of variability here. This is why you have to have these discussions with your neurologists and your nurses to understand this. So I'm going to give you a case study of why we need to do MRI monitoring. And I've given this case study many, many times. This is actually a patient of mine. She's a teacher, 38-year-old. She was on Copaxone for 3 years, and she was very good. She took her injections, and she tolerated the drug very well. And she had a mild relapse. It was a sensory relapse. Okay? She was referred to me to a second opinion because she saw her MS nurse, and the MS nurse said it's a mild sensory attack, it's not important. And her neurologist wasn't keen to switch her therapy, so she'd had a relapse. This happens to be quite a while back, okay? So in those days, there weren't many options apart from, this wasn't that long ago. When she did have that relapse, Tysabri was also available. She came to me for a second opinion, and I switched her to interferon beta because she'd had a breakthrough on Copaxone, and that to me means the disease was active. So we switched her to interferon. She chose Avanex via our Decisions website. She had mild persistent flu-like side effects. Blood counts were slightly low. Okay. We screened her for neutralizing antibodies, was insulin negative, okay, and she was doing well on the drug. She volunteered for a research program. And that research program included MRI scans. And this was done at a stage where our center wasn't doing annual MRI scans. So this was purely a voluntary contribution to research. That scan was not being done for clinical practice. It was being done for research. And it wasn't even being done in my institution, in another institution. Anyway, she developed a whole lot of problems as a result of her MS. She developed fatigue and cognitive problems, and she was forced to take early retirement on medical grounds. Okay, although she was fully functional, okay, she became depressed and anxious, and she was now at home ruminating about her disease. She spent most of her time online on the web and became an expert patient. You know, some of you may do the same. You may spend your time searching and looking for information and all that, okay? And she was pretty widely read, and she'd been reading our blog, and she wanted to know what an MRI scan was. So I got an MRI scan for her, and this showed that her MRI was, you can see that she's got a large number of lesions, and she's got an active lesion that's enhancing there, and that tells you that the lesion's inflamed. It's a new lesion. And she's also got quite a big brain. I mean, quite a lot of shrinkage. These things in the middle are called the ventricles, and they're quite large, so she's lost a little bit of her brain volume. So although this lady wasn't having relapses, her disease was active subclinically, below the surface of the water. And if we had been monitoring her as part of our routine, we would almost certainly offer this lady a more effective therapy. And I've started referring to these lesions as subclinical relapses, because that means we can get over the NICE guidelines. These are considered to be relapses. Okay? And we've got a problem in the UK at the moment, is because we've got this thing what I call a donut hole, is that you really have to fail therapies quite badly to get to the upper tier. You can't just, so if you apply the guidelines strictly, MRI failure is not good enough. You have to have clinical relapses. So there are a large number of people with multiple sclerosis that are on these treatments and their disease is active on their scans that are not being escalated to more effective therapies, and they need those therapies. Because we now know that people who have active lesions on scan do worse than people who don't have active lesions on scan. Anyway, she went for another opinion. Okay, and a consultant colleague of mine, I won't mention his name, managed to find relapses in this lady, and she was elevated to, she was given the choice between tysabri and fingolimod, and she was JC virus positive, so she chose to go on to fingolimod. Okay, she's on fingolimod. Now I'm going to give you two other cases. So this patient, and both these patients are what I call out the closet. They've got MS and they don't mind talking about it because they're in the media. And this guy is called Ian Rogers, and he actually wrote an article about his disease in one of our journals. Okay, I was diagnosed with MS in May 2004, age 39. There were no early signs of anything wrong. Gone on the days when MS was just a disease of where myelin was damaged, loss of neurons and axons are now seen as a cause of irreversible disability. But this guy is a researcher, he's a statistician, and he works for the Department of National Statistics. And he went away and did a lot of searching on the internet, and he wanted to be given the most effective therapy available. And he wanted us to refer him to Canada for a bone marrow transplantation. Now, bone marrow transplantation back in 2004 was a risky, it is a risky therapy. It's got a mortality rate. You've got about a 1 in 100 chance of dying from that procedure. So what they do is they take some stem cells out of your body, and then they really give you aggressive chemotherapy to destroy your immune system. They give your stem cells back to regrow your immune system. And you get really ill on that therapy. So I actually said to him, look, there's some treatment in Cambridge where they'll be able to give it to you as a compassionate called alemtuzumab. That's a lot safer than a bone marrow transplant. So I sent him to Allistic Approach in Cambridge, and they accepted him onto the compassionate alemtuzumab program. And he was thrilled. The day he arrived up there to get his first infusion, they stopped dosing alemtuzumab because there had been a patient in the trial that had developed that complication of low platelets and had a hemorrhage into the brain and died. So the Cambridge had shut down completely their compassionate use program. So he couldn't get his alemtuzumab, so he came back to London, and we put him onto Rebif. And he was on Rebif for 18 months, and during that time he had 2 big relapses. The second relapse was a spinal cord relapse, and he ended up in a wheelchair. And then in Cambridge, they happened to be reopening the trial for alemtuzumab. There's a small trial going on. So he managed to get alemtuzumab as part of a trial. So he had an 18-month delay. So he made a good recovery from that relapse. Unfortunately, he's been left with weakness in the leg and a dropped foot. And his main problems are he can't run anymore. And he used to run marathons with his friends. He can't play tennis anymore. And he said one thing that really frustrates him, because he works in London, he can't run down the stairs to catch the trains and the tube. Okay. So he had a delay of getting alemtuzumab of 18 months, okay, and acquired disability that's with him for life. Okay. I think not being able to run, play tennis, run down the stairs is a significant disability. Okay. Now, in comparison, at the very, very same time, I saw this gentleman. His name is Tony Johnston. He's a professional golfer. He comes from the country I came from, South Africa, and he had bad MS, very similar to Ian, and he was referred to me for an opinion because he'd had a spinal cord relapse and a brainstem relapse, and he had a problem with his hand. His hand wasn't working properly. He had like we call it a deafferented hand. He didn't know where it was in space, and he couldn't play golf, and it was his game. So I sent him immediately to Cambridge to be recruited for the phase 2 trial of alemtuzumab. And he went into the trial, straight away got alemtuzumab, and 5 years after having alemtuzumab, he's made a full recovery. He's back on the senior circuit playing golf, The only symptom he now has is when on a hot day after 18 full run, he may get a bit of pins and needles in his hand. Okay? So these two cases are an example of the dangers of delaying access to people of an effective therapy. Okay? And it's because of the trial program and the results of using alemtuzumab as a first-line therapy. It's been given by the European Medicine Agency and NICE a first-line indication. I'm not saying everybody should take this drug because it's got risks. When the immune system comes back, there's a high incidence of other autoimmune diseases. Okay, thyroid disease, about 40% of the people develop thyrotoxicosis, overactive thyroid. 2 to 3% develop that condition of abnormal platelets, and they can get bleeding. Small number of people get inflammation in the kidneys, so there's a lot of complications to this treatment. And so people who have alemtuzumab have got to realize they've got this risk and have to be monitored for these complications. Any questions? Anybody got any questions? So these cases and this drug is telling us that we should use this treatment early. Now, what is the therapeutic target? Okay, so at the moment, our current target is this term called NEDA, no evident disease activity. So we try and make people relapse-free, progression-free, and we try and switch off the MRI activity. But this is not good enough, in my opinion. It's not good enough. And the reason why it's not good enough is because when we monitor our MRI, we're only picking up stuff at that level. And unfortunately, MS is a microscopic disease, and our current MRI scans are not picking up the inflammation that's occurring in the gray matter, surface of the brain. Even some of the small lesions are not getting detected, and it's not picking up this thing called brain atrophy. People with multiple sclerosis, brains shrink more quickly, and that's not getting picked up in our current metric. And this is just an example of a person with MS dying at the age of 70 compared to a healthy control. And they've got about 30% less brain as a result of MS. Okay? The term I use here is end organ damage. So this disease is damaging the end organ. Similarly to rheumatoid arthritis, it damages the joints. Okay? And when does this process occur? Well, the process occurs across the disease. Now, this is the shrinkage of the brain that occurs in MS. And you can see here, this is the first attack, relapsing MS, secondary progressive and primary progressive. And the brain shrinkage is occurring across all stages of the disease from the beginning. It's not something that happens only in progressive disease. So this process, is there all the time. And there's been this wonderful paper that was published earlier this year. It's called a meta-analysis, where you take all the trials that have measured the shrinkage of the brain, and they've looked at the data. And what they found, that brain shrinkage, this is the atrophy's shrinkage, okay, in the second year of the study, correlates very well with disability over 2 years. And similarly, the new lesions that come on the brain scan also correlate very well. And when you put these together, the R-squared value is 75 or 75%. So the message about this trial is that if you want to make a big difference to people with MS, you've got to stop inflammation, but you've also got to stop the shrinkage of the brain. So you've got to target both these processes. Anti-inflammatory, and the atrophy is what we call neuronal loss, so we've got to protect those neurons from dying. And it's important because not all drugs are equal when it comes to end organ damage. And I've listed now the 8 drugs that are available in the UK. There's been a few weekly positive Avonex trials, but really there's only 3 drugs available at the moment that have a robust impact on brain atrophy in year 2. It's natalizumab, fingolimod, and alemtuzumab. Okay? And those 3 drugs happen to be the most effective drugs as well. So if you have to line these drugs up in terms of their efficacy, these drugs fit on the top of the pile. So the message here is if we really want to get on top of this disease, make the biggest difference to people with MS, is we have to use the most effective therapies. Simple as that. And the rheumatologists discovered this 15 years ago. They had to flip the pyramid around, and to make the biggest impact to people's joints, they had to use the most effective therapies as early as possible or as quickly as possible. That's the message. So there's no point in waiting 5, 10, 15 years to use the most effective therapies. we have to think about strategies of getting people who need them onto the most effective therapies as quickly as possible. And I put this here just to remind you, this is what a rheumatoid joint looks like. We don't see this anymore. Okay, this is a joint replacement. So one of my daughter's best friends' dad's an orthopedic surgeon. He's a specialist in hips and shoulders, knees and shoulders. He said to me, Gavin, 15 years ago, every single list, my surgical list, half the patients on my list for joint replacements were rheumatoid arthritis patients. He said, if I do one rheumatoid patient a month now, it's a lot. One a month, he said. So and the reason is that the rheumatologists started treating joints aggressively 15 years ago and protected the joints. The difference between a rheumatologist and a neurologist is we cannot replace the brain and the spinal cord, you see. So we've got to start thinking about this brain and spinal cord as being very precious, and we really need to protect it. And the only way we can do that in MS is to treat this disease aggressively early on in the disease. And I think I should stop there because we've run out of time, more or less out of time.
Thank you, Professor Giovannoni. I don't know if you've got time for questions or should
I have,
just
yeah,
end
I've got
it
time for questions, but that's why I stopped early, because the end part is very controversial, and I don't want to...
Okay.
Maybe I could just quickly flick. You want me to do it? Okay. Okay. So one of the questions people always ask is, can you cure MS? So to cure MS, which is part of what we're trying to do, is you've got to know what causes MS. And I personally believe we know what causes MS. So these are the factors that have been unequivocally identified as being in the causal pathway. There are a whole lot of genetics, genes, and you can't change your genes. They're given to you by your parents, and you've got them. Okay? Vitamin D and sunlight exposure, smoking, and EBV. All right? Now, people who smoke have a 50% higher chance of getting MS. Unfortunately, a large number of people in this country still smoke, and you don't have to go too far to see teenage girls and boys smoking. So if we wanted to stop people getting MS, we really have to stop people smoking. But that's not going to stop all of MS. Vitamin D, we've got good evidence that low vitamin D levels in childhood and adulthood increase your risk of getting MS. So we really need to do a trial in people at risk of MS of vitamin D supplementation to try and prevent the disease. And if you believe George Ebers from Oxford, who's now retired in Canada, he would say that he thinks 85% of MS can be prevented by vitamin D supplementation throughout life. And that's based on how common the disease is in Tasmania, where you don't have much vitamin D and sunlight, compared to Queensland. So if people migrated from Tasmania to Queensland as children, their disease incidence would drop by 85%. This was before sunblock was used in Australia. So there's no point in modeling that. Saying that you can prevent 85% of MS is a theory. We'd have to test that in a clinical trial. And the other big causal agent is Epstein-Barr virus, EBV. And we know that people who've got Epstein-Barr virus, it's a virus that causes the infection glandular fever. Almost all of us have got the virus, actually. But if you get the virus in adolescence or early adulthood, you've got a higher chance of getting infectious mononucleosis or glandular fever. And that increases your risk by about 2 to 2.5 of getting MS. The important thing is that people who don't have this virus don't get MS. So if we can stop the population getting Epstein-Barr virus, we may be able to prevent MS. And to do that, we would have to do a vaccination trials to stop people getting it. And we don't have a vaccine for EBV at the moment. So anyway, so the hypothesis is that it's an autoimmune disease, and all these things interact with each other to cause multiple sclerosis. So they're like gears, like cogs in a machine. And if we can remove one of these cogs, we can stop the machine. We can stop MS. Okay? And to be honest with you, the only realistic way of doing that is by targeting the immune system, is what I call rebooting the immune system with induction therapy. So the only therapies that we've got that can potentially cure MS are the drugs that are induction therapies, the ones that reboot the immune system. And those are drugs like alemtuzumab, cladribine that hasn't been licensed, bone marrow transplantation. Okay? So what do we mean by MS? So this is the average population. There's somebody with, this is the disability score, and this is the time to reaching these disability scores. And you can see that I've been quite optimistic here, saying that if we didn't treat anybody with MS, 15% of people will have benign disease. Now that's a term I don't like using because most people use it incorrectly. You can only use benign disease when you've had the disease for so many years and you haven't got disabled. And this is a moving target because about a third of patients have benign disease at 15 years. That's an EDSS score of 3 or lower. Okay, 3 or lower. And they've had the disease for 15 years since their first attack. Now, if you follow that group of people up for 25 years, it drops to 15%. If you go to 30 years, it drops to 5%. And when you get to 50 years, it's down to 2.5%. So it's a moving target. Benign MS just depends on how long you follow the patients up. So it's not a common manifestation. Those figures, by the way, are in the pre-DMT era. So now with DMTs, I think the proportion of benign MS will go up because we are stopping this disease causing its damage. Now, a lot of people with MS would say, if you want to cure the disease, I'd like them all to be flatlining with no disability, and that's not realistic because, unfortunately, with MS, if you've acquired some damage already and we've got a cure, it's not going to fix that damage. It may stop further damage from occurring, but that damage is due to the previous lesions that have caused damage. So what we may be doing right now is we may be moving this curve this way, but at the end of the day, all patients end up there. And this is one of the cynical view of things. I actually think this is not correct. I think this orange line should be about there. Because some people, there's many more people now, I think, are going to have benign disease without treatments. Okay? And this is what I would call a cure, is that a significant proportion of people, okay, not just those people, but a much higher people, end up with benign MS with no disease activity. Okay? The thing about this is we can't just ignore this. We've got to look for it. Okay? So our current definition of trying to find a cure is if somebody gets to 15 years after treatment with no evidence of activity. So if we give you a drug like alemtuzumab, an induction therapy, or a bone marrow transplant, and we follow you up for 15 years and you've had no relapses, no MRI activity, your EDSS is stable, we do lumbar puncture and there's no evidence of damage, there's a significant chance that a proportion of those people will go on to 50 years without their disease being active. Okay? So this is controversial, but we have to put this on the table because alemtuzumab, which is a risky therapy, you will never take that therapy unless this was on the table, the possibility that it may put you into long-term remission. Okay? I'm not saying it's going to cure you, but it's a chance that a significant proportion of people may be put into long-term remission that we can call a cure of this disease. And the question, some people still say that MS is actually not an inflammatory disease. Whatever's causing this disease is a neurodegenerative illness. And the inflammation is just secondary to that cause. And that may be true, actually. We don't know that. So the real question is, if we flatline people, put them into long-term remission, and they stay flatlining, then the autoimmune hypothesis is correct. If they come back, say, 15 to 20 years later with secondary progressive disease, it may support the neurodegenerative hypothesis. I put this on the table because this is an experiment that is running right now. We've taken about 1,500 people with MS, and we've treated them early with alemtuzumab. A significant proportion of those, say 60% right now, or even more, it's about 70%, are in long-term remission, and we're going to see what happens to those people by following them up. Okay? So this experiment is running right now, and we'll get the answer in 10, 15 years' time. Okay? The question is, should we stop people getting this therapy until we get this answer? Or should people have the option of having this treatment before this answer is known? Okay, so that's a debate you have to have in your own head. and a debate you have to have with your MS nurse and your neurologist, okay? And I'm terribly upset because some neurologists have said to me in my face, Gavin, I'm not going to give anybody alemtuzumab because it's far too dangerous. It's a far too risky therapy. That's what their attitude is, okay? I won't mention the names of these neurologists, but I was absolutely flabbergasted. Is that they're taking that off the table for some of their patients. You can't have that option until I know what this answer is. Where some other neurologists are saying, no, as long as people understand the risks of these therapies, they can make the decisions themselves, okay? Just to say that there's a therapeutic, I talk about a therapeutic pyramid. I believe that MS is an inflammatory disease. We've got to switch off the inflammation. Those nerves that have been damaged, we've got to protect them and keep them alive. So we have to add on a therapy to protect them so they can remyelinate, okay, and restore function. So there's a thing called, where we're going in the future with MS therapies is not one treatment, but we're going to start doing combination trials to try and test this strategy. And one of the problems that's going to emerge is that some of MS progression has got nothing to do with the disease, but it's got to do with aging. Okay, we know from other diseases that when you have inflammation in the brain, it prematurely ages the brain. Okay? It sets off motion so the brain, and we can't at the moment treat aging. So even though we may have very effective therapies, some of the features of progressive disease may not be manageable by this approach. We may have to target aging, which is why me as a clinician now telling people about brain health. Brain health is about how you protect your brain for old age. And there are things we can do to protect our brains for old age. Stop smoking, lose weight, exercise, make sure if you've got hypertension, it's controlled, make sure your diabetes is controlled. There's lots of things you can do for brain health. Okay, so the concept of brain health comes from the Alzheimer's field. It should apply to MS as well. And just to make sure, because a lot of people in this audience have got progressive MS, we haven't given up on progressive disease. So this is just a slide just to show you that all the trials that are happening at the moment addressing the underlying pathology of progressive disease. So there's a large number of trials happening at the moment. And I'm actually quite confident that one of these trials is going to be positive. And the first one to report will be the fingolimod primary progressive trial. We'll get a press release from the company late November, early December, of whether or not fingolimod is effective or not in primary progressive MS. Okay? So people with progressive disease, please, there are things happening in the space to try and slow down the progression of the disease. I shouldn't put this up. This is causing trouble. But anyway, let me put it up. So there's this thing called the diffusion of innovations. And you may ask yourself, why doesn't my neurologist offer me these more effective therapies, whereas a neurologist down the road does? And the reason is that we all adopt innovations at different rates. Okay? So this is a particular curve was described by a guy called Everett Rogers, and he was he was a sociologist really, and he was studying agricultural technologies. Why do some societies and communities adopt agricultural innovations very quickly and improve their farming output, whereas other communities wouldn't adopt them? And similarly, when it comes to adopting early effective therapies, there are some people that are innovators, like Alistair Compston, Alistair Coles, who developed alemtuzumab, are the innovators. There are people like me who are early adopters. I will offer it very early on. There are some people who will wait until other people are using the drug before they do it. There'll be some people called late adopters who will wait 3 or 4 years to get more data. And there's some people who will never accept it. Okay? And this particular curve applies to neurologists as well, obviously. Okay? So the reason why I'm saying this, if you don't think you're getting a good deal with your neurologist because they are late adopters or laggards, you need to get a second opinion. Simple as that, all right? If they don't agree with what you're thinking about your disease, get a second opinion.
You won't put names on that graph for us.
Okay. Ask a general practitioner. There's a thing called the NHS Charter. And the NHS Charter has a clause in it stating that you are allowed a second opinion. Okay? I'll put this up. You recognize the picture? It's at Escher. And there's a white swan going to a black swan. And we may have this all wrong. Okay? MS may not be an autoimmune disease. It actually may be due to a virus, and what we're seeing is the inflammation against the virus. Okay? And that's why our group at the Royal London Hospital have got this thing called the Charco Project, where we're trying to investigate the viral etiology of MS. And we've got trials running. We've got a trial of a drug that's used in HIV to treat MS, and there is some data supporting this. And we'll get some results on this early trial next year. And we've got a whole lot of other trials planned. And the reason why I say this, there's lots of discrepancies in the autoimmune model. You know, if autoimmunity was really the answer, it should explain everything. And there are lots of little holes in the theory that I don't feel comfortable with. And I think the viral etiology explains those holes a lot better. So I'm not going to stay blinkered and just think this disease is definitely autoimmune. We've got to keep an open mind. Okay, so I call that the Black Swan is based on a book about rare events, things that change paradigms. Okay, so we are investigating whether or not we can change the paradigm by treating MS with antiviral drugs. And for those who want to know about remyelination, there's a whole biology around remyelination. And I did this for our recent meeting in Ectrans just to show you that there are a large number of compounds that are currently in clinical development to remyelinate, okay? To take damaged axons and remyelinate them. And the hope with remyelination is actually that it will improve function, rather than just stop yourself getting worse. And there are really interesting techniques for showing improved function, and these are the techniques that are included in these trials. So there's lots happening in the space. You'd be surprised how many drugs have been tested as remyelination agents in MS. I think I'll stop there then. These are the conclusions. I'll put this, by the way, I'll put this talk up on the web if you want it. It'll be on that on my MS blog site, and you can download it if you want more information. Thank you very much.
Thank you, Professor Giovannoni. Professor Giovannoni's talk concludes today, and I'd just like to thank everybody for attending today. I know it's been a long day, but hopefully a beneficial one to you all. As ever, the feedback that we get from these sessions are important for informing future events. So if you could just, before you leave today, if you could just go through the feedback form using the clicker, that would be very beneficial to us. And also, if you've got any additional feedback that you'd like to give us, please look at the back of the agenda that you should have received upon entry, and there's a website for the MSTC charity, which many of you would have registered on, and you can give us additional feedback that way. Thank you.